all of you that joined, and let me just tell it that I got the recording. I just want to say that all of you, excuse me, that joined, you are the reason that we can move a body of knowledge forward. The people that come and devote 3 hours on a Sunday to a talk, you are the reason that we can move a body of knowledge forward. And we're all here because we want to change outcomes for our patients. And so today, my talk is not so much on what we do and how to do it, but it's why we do it. And I think once you understand why we do what we do, then it just enlarges everything that we do, and it makes us more engaged in what we're doing instead of being detached. Our job is not needles in and needles out. Our job is to change outcomes and to change quality of life for our patients. So today, we're going to talk about oxygen, and you're going, oxygen in dialysis, what? Well, yeah, oxygen isn't everything, but it's right up there with money. So we'll go to the next slide. So what our objectives are today, we're going to review hypoxemia. Hypoxemia is too little oxygen in the blood. And whenever you have a problem with what does something mean, what is the definition, just break it down. Hypo, too little, oxygen, emia in the blood. And there are problems, acute problems, which is what happens right now. The patient passes out or they get dizzy. And then there are also chronic problems, and the chronic problems are changes in the left ventricular area, changes in the muscles, changes in the brain. We're going to talk about how we measure oxygen saturation. What are the normal and abnormal numbers? You have to know what normal is before you can make an intervention. If you don't know what normal is, then you don't understand what numbers are. So we have to talk about normal. And of course, I always say normal is not a number. Normal is a range. And one of the things I love to do, I love to go to somebody like my colleague Gloria, who's listening, and say, well, what is the normal height for a woman? And then the shortish people tell me anything from 4'11" to 5'2". They say that's what normal is because that's how tall they are. And I say, excuse me, you're telling me I'm not normal? I'm 5'9"? And then they go, oh, well, plus or minus. So normal is not a number, it's a range. We're going to discuss what happens when your dialysis oxygen level is too low for too long, and how does that contribute to hospitalization and mortality. So these are our objectives today, and these are specifically for the dialysis patient. Next slide. So first of all, what is hypoxia and what happens when your patient is hypoxic? Next slide. So the definition, like we discussed, it's an inadequate supply of oxygen to the tissues. So oxygen is based on supply and demand. And you can have an amazing supply of oxygen, but if it's not getting to the tissues, if that oxygen for some reason is not getting to the tissues, that patient has hypoxia. Next. So these are the terms that we use in our clinical places, whether you're in the acute unit, the subacute unit, the chronic unit, in rehab, home therapies. So all of these terms have to do with oxygen, and they have to do with too little oxygen, and they're all an interruption of the supply or the demand in the chain, in the physiological chain. So anoxia is a total absence of oxygen. That's like if I'm going to hang and you just cut off my supply right here at my throat, or if a baby is, a fetus is pressing down on the umbilical cord, then that baby's going to have anoxia, no supply of oxygen to the brain, and then be born with cerebral palsy. So anoxia is any cutoff of the supply. Hypoxia is too little, the oxygen supply is reduced. Ischemia is when the tissues themselves are not getting the blood that's carrying the oxygen for whatever reason. The arteries are blocked, or there's a tourniquet, or something is going on, and then ischemia is not enough blood supply. And if there's not enough blood supply, then of course muscles and bone and all of that dies. A lot of patients have to have a hip replacement because they have avascular necrosis. So avascular means no blood supply, necrosis means death. And so with ischemia, tissue is dying because it's not getting its oxygen. Hypoxic hyper. What? Weird. That's like saying yellow jaundice, right? So that's a reduced partial pressure of oxygen. And that could be you're climbing Mount Everest, the altitude, or you have lung disease, or you're just not breathing deep enough. So you have hypoxia because you're not getting enough oxygen into the lungs. Anemic hypoxia, and that's the most common kind of hypoxia in our patient population. They do not have enough hemoglobin to carry the oxygen to the tissues that are needing the oxygen. So hemoglobin is your oxygen carrying protein, and hemoglobin is really important. And that's why in our world, we're doing blood counts and hematocrits and hemoglobins weekly, and the nurses are giving Mircera and EPO and Aranesp and iron. That's all to increase the hemoglobin because it's the oxygen carrying protein. Stagnant hypoxia is when your blood flow is just sluggish. Even though you've got enough hemoglobin, you're not on the top of Mount Everest, you're at sea level, and your blood flow is just sluggish, or your heart's not pumping properly because you've got left ventricular hypertrophy or congestive heart failure, or you're in circulatory shock. We took off too much blood flow, or we took off too much volume during dialysis. Your patient has hypovolemia, so there's just not enough blood flow. And then finally, histotoxic hypoxia. That is when the cells themselves cannot use the oxygen that is given to them. And those are the patients in our world, mostly sepsis is the reason for that. And then of course, you know, there are other reasons like cyanide poisoning or carbon monoxide, those kinds of things. So the cells themselves cannot use the oxygen that's delivered to them. So that covers the terms that we'll be using. And sometimes hypoxia and hypoxemia are used interchangeably, but technically hypoxia is really hypoxic hypoxia. But we kind of use them interchangeably, but this is very digging deep into all of the terms that have to do with oxygen and too little oxygen and why we have too little oxygen. Okay, next. So here is a huge, big surprise. In the literature, and you can see, if you look at the citation at the bottom of the slide, you can see that in 2000, in a textbook, hypoxia was one of the complications of dialysis. Well, that's 20 years ago that this textbook was published, and somehow we haven't wrapped our heads around what our patients need. And then more recently, there's an article on hypoxemia, and that article is 2016. So that's a good 5 years ago. So we know, we absolutely know that hypoxemia occurs in nearly 90% of patients during dialysis. So if you think of your 10 patients that you have, if you have 10 patients, you and another tech, or the nurse has 10 patients and 2 techs or 3 techs, 9 of those patients statistically will have hypoxemia during the dialysis treatment. That is quite a shocking number. So does that make you think maybe we should have the oxygen regulator plugged in behind the wall, and we should just be able to hook up our tubing instead of going to go get our oxygen concentrator or our oxygen tank and open it up and check the pressure and turn it on and all of that. You know what I'm talking about. Then the same research and literature looking at many, many patients has found that prolonged intradialytic hypoxemia, this prolonged hypoxemia is happening in 10% of our patients. So we know that hypoxemia occurs in 90% of patients. It might not be for the entire treatment. It may be just for half an hour or in the middle of the treatment or at the end of the treatment. But in the patients where it's pretty constant, which is 10% of the patients, which is a third of your treatment time. So if your patient is a 3-hour run, for 1 hour they have hypoxemia, that is a cause of hospitalization and mortality. And one of the metrics that we're using in the United States, in order to get reimbursement from the government for the treatments, one of the metrics we use in the United States is your readmission rate, your hospitalization readmission rate. The government is looking to see, did your patient get readmitted within 30 days? And why did they get readmitted? So if you want to prevent your readmissions, if you want to do anything you can to prevent hospitalization, and who wants to go to the hospital today in this day and age where you potentially can go to the hospital with a negative COVID test and come out of the hospital with a positive COVID test. And anecdotally, I've heard that that has happened where patients who were negative 5-6 days after their heart surgery started having symptoms. They did a COVID test and they were positive. So somehow this, and especially with this Omicron variant, it's very transmissible. So the one thing we can do for our patients is everything we possibly can do to keep them out of the hospital. And of course, whenever you have hypoxia during dialysis, that can contribute to your hypotension, your nausea, and your muscle cramps. And of course, normally when our patients dump their blood pressure, what do? We either turn off the UF rate or we open the bag of saline and we give them 200 mils of saline. And just to make a point, what dialysis is supposed to do is dialysis is supposed to remove sodium and it's supposed to remove fluid. So that begs the question, why are we having to give them saline? Because we're not being proactive. Also remember that 1 bag of saline has 9 grams of sodium in it. So if you give your patient half a bag of saline for your, just say 400 mils just for your prime and your rinse back, you're giving your patient 4.5 grams of sodium. Then you have the dietitian going around telling the patients, now you've got to limit your sodium. You can't eat the hot dogs and you can't eat the ham and you can't eat the prosciutto and you can't eat the pastrami. It's too high in sodium. So the dietitians are wanting to limit our patients to 2 grams a day. American Heart Association actually says we shouldn't have more than 1.5 grams a day. But nonetheless, if the patient is compliant with their diet, and that's a big capital IF, then they're getting 2 grams of sodium a day. We're giving them 4 or 5 or 6. They're leaving our dialysis units with a sodium burden of, say, 6 grams, 2 grams from their diet, 4 grams from our saline. What are they going to do? They're going to be really thirsty. They're going to go home because they've got to bring their sodium levels down. So this hypoxia, when you look at hypotension, you have to ask yourself, what do I need to treat my patient with for this hypotension? Do I need to give them oxygen or do I need to give them saline? Those are just questions which I want you to keep in the back of your brain. And then, of course, muscles that are not getting enough oxygen. If you start climbing Mount Everest or you start running up the mountain and you are not breathing quick enough or your hemoglobin's not good enough, you're going to start cramping. Your muscles are going to start begging for oxygen. You're going to stop running up the mountain and you're going to go, what are you doing? You're getting a good deep breath. You're getting oxygen to your muscles, and then hopefully your cramp goes away. So the same thing's happening to our patients on dialysis. And remember, dialysis is work. Energy expenditure is increased on dialysis. So actually our patients lying in the bed or sitting in the chair are using more energy. It's actually physiological work. And any work that you do requires fuel. Next slide. I kind of like how it takes a while for the slides to move on, because you could sort of just look at all the writing and start processing the information and maybe even taking some notes. So this article, published in 2016, says that 10% of the treatment time, our patients on dialysis have an oxygen level of less than 90%. Any oxygen level less than 90% is clinically significant. 10% of your patients are having that oxygen, or 10% of their treatment time. That's everybody, 10% of their treatment time. 3% of the treatment time, it's less than 87%. So what does that mean? It means that when you have prolonged hypoxemia, when your oxygen levels are decreased for a longer time, 10.2% of patients who spend 58% of their time with an oxygen level less than 90 and 20% of their treatment time with an oxygen level less than 87%, those patients are using more EPO. They didn't look at Macera and Aranes, but those patients are using 1,300 units more EPO per treatment. And then we always have the bean counters telling us to cut costs, right? Well, we all know that EPO costs a lot. And so the balance is, do you want to give your patient EPO because they're hypoxic during their treatment, or do you want to treat them with oxygen, which will also help all of the organs in the body? So those are just questions to make us think, what is best for our patient, and how can we also at the same time cut costs without a deficient dialysis treatment? And I think if we aren't giving our patients everything that they need in order to have dialysis efficiency, then we're doing them a disfavor. Next slide. So what happens when you don't have enough oxygen in your body? What happens to your body? What happens to your thinking? What happens to your heart? What happens to your kidneys, your gut, your lungs? Well, first of all, it affects the cardiovascular system. The heart's job is to pump and to send the blood that's carrying the oxygen to all the tissues in the body. So the heart actually has to work harder, and when the heart has to work harder, the left ventricular or the left ventricle gets bigger. That's left ventricular hypertrophy. And then over time, the heart, by working so hard, says, oh my gosh, I'm just so tired of doing all this pumping. And then it can stretch out and get floppy, and then you don't have good cardiac output. And then you have arrhythmias, or you have congestive heart failure. So the number one organ that gets badly affected by low oxygen levels is the heart. We all know that in the world of dialysis, our number one cause of mortality is cardiac. Our patients die because of heart problems. The next thing that happens is wound healing. So as you know, the majority of our patients have diabetes. And one of the problems with diabetes is wound healing. Well, one of the problems with lack of oxygen to the tissues is wound healing. So every muscle cell, every bone cell, every gut cell needs oxygen. In fact, every cell in the body needs oxygen. So if you want your cells that have, say, osteomyelitis or cellulitis or a venous ulcer, if you want your cells to heal, then you need oxygen. And that's why we have hyperbaric oxygen chambers. You know, the patients that have severe wounds, they go into that hyperbaric oxygen. Well, too little oxygen interferes with wound healing, which is not good for our diabetic patients at all, because in the end, they end up getting lots of antibiotics like vancomycin, or they end up being admitted with sepsis. And then lack of oxygen also affects the pro-inflammatory pathways. And we know with COVID that one of the problems is the cytokine storm. Well, cytokine, that has to do with your pro-inflammatory pathways. So if there are any viruses or bacteria out there, the patient who's not getting enough oxygen has higher risk for infection and higher risk for any kind of cytokine storm, such as in COVID. And then, of course, it affects the central nervous system. That's the brain and the nerves. And the reason for that is the brain and the heart are the two organs that need the most oxygen to do their work. So if you're depriving the brain and the heart of oxygen, then they're going to have problems. Next slide. So when we are on our clinics and in our units and doing our vital signs, we're asking our patients how they are, and they complain of cramping, or they complain of dizziness, or they feel like they're getting nauseous. One of the things we do is we turn off the UF rate, or even for cramping and low blood pressure, we'll give them saline. However, we need to remember that these are all of the signs and symptoms of hypoxia. So shortness of breath, rapid pulse, low blood pressure, cramping, rapid breathing, cyanosis, little blue around the lips or little blue at the fingertips, dizziness, nausea, blurred vision, confusion, and even sometimes the voice. You know, the voice sounds a little dry, and okay, maybe the patient's too dry. But those are also all the signs and symptoms of hypoxia. So we need to start teasing away what's going on and asking ourselves, what is the best treatment for this patient at this time? And since 90% of the patients have some kind of intradialytic hypoxia, then, I think you can kind of connect the dots and go, what should we be doing over here? Next slide. So this is really one of the most important slides. And I think if you have a piece of paper and a pen, kind of write this down, because this will just bring it all together in your mind. When we do physiology, we talk about the transport and the utilization of oxygen. And we're going to discuss each of these little blocks separately. So first of all, the oxygen has to go across the alveolar capillary membrane. So you breathe it in, the oxygen comes from the atmosphere into your lungs, and then it crosses that alveolar capillary membrane. It goes from the lungs into the blood vessels. Then once it's in the blood vessels, you have hemoglobin, and the hemoglobin is the oxygen carrying protein, and the hemoglobin picks up the oxygen, and then the lungs send the blood to the heart, and the heart says, thank you very much. The hemoglobin has picked up the oxygen. Now cardiac output, the heart is going to pump the oxygen to the tissue bed. And so the heart pumps, and then the oxygen goes in the arteries to the tissue bed. And the tissue bed is every cell in the body, whether you want to talk about the muscles, the liver, the kidneys, the gut, the spleen, the pancreas, the brain, the heart, and then the blood goes by, and the hemoglobin's carrying the oxygen, and then the hemoglobin actually gives up the oxygen. It says, hey, tissue bed, I have a gift for you. I picked it up in the lungs, and the heart sent me to you, so here's my gift, take my oxygen. And then the hemoglobin releases the oxygen. And hemoglobin is pretty special because it makes a reversible bond. In the lungs, it says, oh, hemoglobin, I love you. And it picks up the hemoglobin and it says, let's be together forever. But once the hemoglobin gets to the tissue bed, it says, you know, oxygen, I'm done with you. You can go. And then the hemoglobin gives up the oxygen, and then every cell takes the oxygen. And then finally, even though your oxygen was enough in the lungs, you had enough hemoglobin, your heart's pumping okay, the hemoglobin gave up the oxygen, the cells themselves have to be able to utilize the oxygen. It doesn't help if I tell you to take your binders and you eat all the cheese and the hamburgers and you drink all the milk in the world and you don't take your binders. You have to utilize the medicine that I'm giving you. And if you don't, you're going to get into trouble. And it's the same with the cells. The cells have to be able to utilize the oxygen that is delivered to them. So this is the kind of the circle of life when it comes to oxygen. And every single one of these steps is really important. And that's what keeps us alive. That's what homeostasis is. Homeostasis is us maintaining all of our bodily functions from the top of our heads to the bottom of our toes. Next slide. So this is the lungs. And as you know, the oxygen gets breathed in and it goes to all the little alveoli, which are the little balloons that hold the air. And then the oxygen crosses over those membranes and gets into the blood. So right at the pulmonary level, we have to have everything lined up. And I think the next slide tells us how we have everything lined up. So on the very next slide, this is your dialysis patient. And right the very first step for the transport and utilization of oxygen. First of all, your patient has to be breathing and getting that oxygen in. And what happens on dialysis, because of our dialysate, and we actually make, you know, our patients are acidotic, right? We all know that. And then we've got the bicarb in the dialysate. And then that bicarb gives the patient a relative alkalosis. And what that does, one of the things that it does is it causes hypoventilation right at the little alveolar, which is the little air sacs in the lungs. And then also through the dialyzer, we're actually losing carbon dioxide. We don't use acetate dialysis, so we can kind of skip over that. But right on dialysis, we are causing a relative alkalosis, which causes alveolar hypoventilation. Hypo is too little, too low. The patient is not breathing deep enough to even get the oxygen into the air sacs so that it can get into the blood. So that's number one reason why we could have hypoxia right at the pulmonary level. Secondly, if your patient is fluid overloaded, notice I didn't say when, but if your patient is massively fluid overloaded, then you have pulmonary vascular congestion. You have all that water and you can hear those rattly lungs. They're wet, they've got bronchi, they've got rolls, they've got crackles, the patient is coughing. Then that also interferes with the transfer of oxygen to the alveolar capillary membrane. COPD and asthma. We have a lot of patients who are smokers. We have a lot of patients who have construction type lung diseases. Just because the patient has kidney failure, we also have to remember that there are also a lot of other medical problems that our patients bring with them to dialysis. And we need to address all of their medical problems, because I think one of the reasons Michael and I, and even Gloria, I know for sure, one of the reasons we're in dialysis, one of the reasons we love what we do is because it's so holistic. You get to treat the whole person. You don't just get to clean out the blood and be a fake kidney. You're seeing the patients on a regular basis. you're actually contributing to their quality of life, you have a relationship. And so that's the awesome thing about dialysis, is it's holistic. It's the most holistic form of clinical care that I know of. So think of your patient's lung disease. Do they have emphysema? Do they have asthma? And you can ask them, do you use inhalers? Do you have a small volume nebulizer? Do you wheeze? The nurses are supposed to be doing the assessment. They're listening to the lung sounds. Restrictive lung disease. So if you have a little old lady who's got osteoporosis, she's all bent over, that's squishing her lungs, and no matter how deep a breath she takes, she cannot expand her lungs. So she has restrictive lung disease. There's obstructive lung disease, like emphysema and asthma, and there's restrictive lung disease where it's more mechanical. If your patient keeps their fluid in their bellies, then the abdomen pushes the diaphragm up because there's all that fluid in the belly. Or if the patient has liver disease and they have ascites, that pushes the fluid up, the diaphragm up, and that squishes the lungs. And no matter what the patient does, they cannot expand their lungs, so they're going to have hypoxia. Pleural effusion, of course, that would be the fluid in the pleural sac, and that also squishes the lungs. And the lungs do not have an unlimited ability to expand because they're enclosed in a sac, the pleural sac. So if you have a pleural effusion, then that's going to also contribute to hypoxia. And the interesting thing is when they looked at complications of dialysis, they did some x-rays, pre-dialysis x-rays, and they found that 28% of those patients who had pre-dialysis chest x-rays had pleural effusions. And the chest x-ray only will show you the pleural effusion if you have more than 500 mils of fluid in your pleural sac. So that's a pretty interesting statistic that we can almost assume that a handful, at least a quarter of our patients potentially have pleural effusion. And that's another reason that we need to get all the fluid off of the patients that we can, because if we don't, then we're leaving them with this pleural effusion that we don't even know about. It's subclinical. And when they have that pleural effusion, they can't even take deep breaths and fully oxygenate. And then, of course, the lung dynamics, mechanics change in end-stage renal disease. They found that your forced expiratory volume and your forced vital capacity, those are reduced just in end-stage renal disease, and they postulate that uremia damages, well, we know uremia damages a lot of stuff, right? That's why we're doing dialysis. And then also the diffusion capacity of the lungs is decreased in end-stage renal disease. That's what DLCO is, the diffusion of the lung with carbon monoxide, am I right? Then we have interstitial lung disease. That's actually interstitial lung disease. That's a typo. Our patients are on a lot of drugs, particularly cardiac drugs, blood pressure drugs. And for example, one of the side effects of amiodarone is something that regulates your heart rhythm. It's a lot of your cardiac patients are on amiodarone. The cardiologists will prescribe it, but one of the side effects of amiodarone is interstitial lung disease. So that's why as nurses, we need to know what drugs our patients are taking, and we need to know what are the side effects of those drugs, because those drugs can affect our entire dialysis treatment and be not good for our dialysis patients unless we make some kind of intervention to mitigate the side effects. And of course, pneumonia affects our lungs, and calciphylaxis. And this is another interesting statistic. When they did post-mortems on dialysis patients, they found that 79% of the dialysis patients had calciphylaxis. They had little lesions in their lungs. In fact, they had these calciphylaxis lesions in their hearts, lungs, and stomachs, and it was both adults and children on dialysis. So if you think that up to 79% of your patients have calciphylaxis, and we don't even know about that, this is all post-mortems, and all of that is in this textbook, the pulmonary problems in hemodialysis patients. So it's really interesting what's going on in our patients' physiology. And obviously, you know, these are things that we can't change, but these are things that cause hypoxia, and we need to be aware of them. And that's right at the pulmonary level. We haven't even got to the hemoglobin and the cardiac output and the hemoglobin giving up the oxygen and the cells using the oxygen. So right at the pulmonary level, right at the bat, before you even put those needles into the graft or the fistula, or before you even hook up that catheter, what's going on with your patient's lungs, and know your patient's pulmonary history, and listen to your patient's lungs. And if they're coughing, ask them why they're coughing. They could even have lung cancer without you even knowing it. Okay, next slide. I also kind of like the lag in the slides because we can look at all the data points and then I can catch my breath. So, okay, we're still talking about the lungs here and oxygen diffusion and reduced blood oxygenation. So very specifically, fluid overload. That's how we can help our patients not have hypoxia, is by being sure that we get them to their ideal dry weight. So fluid overload is a huge problem. Pulmonary congestion, pulmonary calcification, that's where we have to encourage our patients to take their binders, and the dietitians work really hard on that, and that's to prevent this from happening. And then there's also, when you are doing blood volume monitoring and you're actually looking at your blood volume reduction and your curves, what the literature has found is that as your blood volume comes down, because you're doing adequate fluid removal, you're actually increasing your oxygen saturation. And then the other thing that is increasing your oxygen saturation when you decrease the blood volume is by decreasing the blood volume, you're increasing the hemoglobin, and hemoglobin is your oxygen carrying protein. So if you have more hemoglobin in relation to the volume in the blood, then you'll have better oxygen carrying capacity. So fluid is a huge issue, and it's something that we can do to help our patients to normalize their blood oxygen levels, which is the fuel for all of the cells in their bodies. And then also, the last thing that the literature and the researchers have found is, we're going to talk about PIH. That stands for prolonged intradialytic hypoxemia. That's the patients who have hypoxemia for more than a third of their time. In those patients, they have found that they actually had higher interdialytic weight gains. So if you have a higher weight gain, then your fluid status affects your oxygen saturation. So kind of fluid and oxygen, when it comes to the lungs, are intertwined. You're not going to fix the one without dealing with the other. So we have to deal with fluid. We have to be very aware of our patient's fluid status. We have to do whatever we can to normalize their extracellular volume, because the one thing that it affects badly is the lungs, and that interferes with the exchange of gases right at the alveolar capillary level. Next slide. The other thing that is fairly common in your dialysis patients, and the neurologists and the cardiologists and the pulmonologists they know about sleep apnea, and they know that sleep apnea has a higher incidence in your dialysis population. And our dialysis patients also have a higher incidence of sleep disordered breathing. One of the hypotheses for sleep disordered breathing is that the uremia, the high BUN, affects the sleep center in the brain, and that interferes with the regulation of breathing while the patient's asleep. But this is one of the pathways for sleep apnea in chronic renal failure. And I know when you're walking around, you're doing your vital signs, you're checking your machines, and your patient kind of dozes off, and then, you know, they're kind of snoring, or they're being noisy, or they stop breathing for 2 minutes or 1 minute, or, you know, they're kind of jerking. Then you want to think, oh, does this patient have sleep apnea? So with volume overload, that affects the airways, you know that, and then that destabilizes that sleep center in the brain, and that gives you sleep apnea. And then uremia also, they think, affects the sleep center in the brain. And then, of course, if your patient has other conditions, we know that high blood pressure is a cause of sleep apnea. So we have many patients who come to dialysis and their diagnosis is hypertension. So the question is, what came first? I mean, is it the hypertension that caused the kidney failure? Or is it the hypertension that caused the sleep apnea that caused the kidney failure? We don't know. But we do know that sleep apnea is very common in our dialysis patients. Okay, next slide. So hemoglobin. As you know, hemoglobin is the oxygen carrying protein. And we have 25 trillion red cells in our bodies. The red cell is the most abundant cell in the entire body. So what does that tell you about oxygen? The one cell that has the hemoglobin that carries the oxygen, that is the most abundant cell in the body. So hemoglobin and red cells are extremely important because every single cell in the body needs oxygen. Next slide. So in our dialysis patients, we were talking about fluid overload, remember? Hemoglobin is a volume dependent number. When I say my hemoglobin is 10, it means that I have 10 grams of hemoglobin per deciliter. So hemoglobin is grams per deciliter. If I want to increase my hemoglobin, I can either give myself more red cells, having a blood transfusion, or having EPO or Mircera, which tells the bone marrow to make more red cells, or I can bring the fluid level down, and then that'll increase my hemoglobin. So there's an inverse relationship between hemoglobin and your blood volume. And high fluid levels, hypervolemia, dilutes your hemoglobin, which affects your oxygen, so causes inflammation. And when you have inflammation, then you don't have the same response to your EPO, your Mircera, your Aranesp. So it's really important to manage the fluid in order to manage the hemoglobin, in order to have more oxygen carrying capacity. And whenever we do our erythropoietin stimulating agents, whenever we're doing anemia management, we're getting our lab values before we have ultrafiltration. So we're dosing our ESAs based on a pre-dialysis blood test, and it's not accounting for volume. But volume is really important because volume dilutes the hematocrit secrete and it dilutes the hemoglobin. And then whenever you have hypoxemia, then the death of the red cells is actually increased. Red cells are supposed to live for 120 days. And we know in our dialysis patients that they have a much shorter lifespan. And one of the things that contributes to the shorter lifespan of the red cells is hypoxemia. So it's really important to manage our fluid so that we can manage our anemia, so that we can keep our patients oxygenated. Next slide. So cardiac output. Once you have the oxygen in the lungs and it's gone into the blood, then those blood oxygen carrying hemoglobin molecules go to the heart, and the heart's job is to pump the blood. Oh, Gloria has to go to work. Okay, bye-bye. Once the oxygen gets to the heart's job is to pump the blood to all of the tissues in the body. So we have to have a good heart in order to have good oxygenation. Next slide. Now this, I think, is the most important slide in this entire presentation. So listen up. It looks so complicated and so busy, but we're going to do it one row at a time. The very top row is your blood flow in mils per minute, or what percent of the total blood flow does every organ use. And we'll just look at the heart. You can see the heart is only taking 4.5% of the blood flow. And then if you go over to the kidney is taking 20% of the cardiac output. So you can see that the liver and the kidney are taking most of the cardiac output in terms of percentage. You can see that the heart is actually taking the least amount of blood flow. Then we'll skip the next row that talks about organ weight. And then we'll go to blood flow, the third row, which is mils per minute per 100 grams. So what that is how much blood is going past that particular organ based on the weight of the organ. So for every 100 grams that organ weighs, this is how many mils of blood it's getting when the heart pumps. And you can see that the kidney is dominating blood flow. Kidney is going, I just need tons of blood flow. So basically the bottom line is that the kidney is a high flow organ. The kidney needs volume to do its work. Finally, we'll go down to the bottom row, and that is the AV, which stands for the arterial minus the venous oxygen difference. So the arteries take the blood to the tissues take out the oxygen they need, and then the venous blood has a lower number and it goes back to the heart so the heart can send it to the lungs. So how much oxygen is every organ extracting out of the blood? And you can see that in every 100 mils of blood that goes by it, the heart is extracting the most oxygen. So what that tells you, and then you can see that the brain also needs a lot of oxygen, right? The brain and the heart need the most oxygen to do their work. The liver and the kidneys need the most volume to do their work. But you can see that the heart needs more oxygen than any other organ in the body. So we've been talking about cardiac mortality. We've been talking about our kidney patients die of heart problems. We've been talking about cardiac output. And the reason we're talking about cardiac output also is blood pressure is cardiac output times peripheral vascular resistance. So if you want a good blood pressure and you want to have good cardiac output to deliver all of the nutrients to the cell, then you've got to give the heart the fuel that it needs, and the heart needs oxygen to do its work. So every little heart cell, in order to pump, in order to contract, in order to pump that blood through the body, needs fuel, and it needs oxygen. And if you're going up the hill and your car doesn't have quite enough gas in the tank, you're going to splutter up the hill, and you might even stop halfway up the hill when you run out of gas, right? Well, oxygen is fuel for the cells. So if you want the cells to work hard and give you a good blood pressure, then be sure they have enough fuel to do their work. Next slide. So we're still talking about the heart. And when we have our dialysis patients, we know that because of this chronic inflammation, remember fluid overload causes inflammation, and of course uremia, high BUNs, that also causes inflammation. So that inflammation and the changes in their vascular smooth muscle accelerate arteriosclerosis. The arteries get hardened. And then in patients with CHF, congestive heart failure, and sleep apnea, it's not only how often they have low sats, but it's how long they have low sats. That hypoxic burden, it's a burden to not get enough oxygen, predicts more hemodynamic stress. And we're trying to protect the heart, we're trying to change outcomes, we're trying to prevent hospitalizations. So obviously when we talk about the heart, we have to talk about oxygen, and we have to consider oxygen supplementation. Next slide. So we're still talking about the heart. And then, Michael, you'll just stop the slides when we need our break, right? Say in 5 or 10 minutes. So we're still talking about,
yes,
okay, we're still talking about the heart here. And we don't look at all these labs, and we don't do EKGs in our chronic dialysis patients, and we just kind of needles in, needles out, and let's get them to their dry weight, and let's get them on the scale and on their way back home. However, we know that hypotension has a pretty high rate in our dialysis patients. There's a 20 to 30% of our patients have some kind of hypotension during the dialysis treatment. And of course, blood pressure is cardiac output times peripheral vascular resistance. So what's going on with the heart here? When they measured troponins 44 hours after dialysis sessions in which the patient had hypotension, they found elevated levels. Now, troponin is what is released by your heart in response to injury. When you complain of chest pain and you go to the emergency room, they measure your troponins, and if your troponins are elevated, then it's most likely because you had a heart attack. It's because you have cardiac muscle injury. But in the dialysis patients who had hypotension during dialysis, when they measured troponins 44 hours after that dialysis session where they had hypotension, those patients had elevated troponins. And we know that elevated troponins are predictive of mortality. So obviously hypotension during dialysis is damaging to your heart, and down the road predicts mortality. Then they also did EKG as far as 1989. They found if they did EKGs on any patients who had hypotension during dialysis, they had some ST depression. So you know the EKG goes P, Q, R, ST. So it's kind of measuring the little waves. And then there's the ST segment right after the ventricles have contracted. When that's depressed, then that is a sign of ischemia to the heart muscle. And in the patients that had hypotension, they found the silent ST depression. And these patients didn't have plaque rupture or any kind of clots to cause this. It was most probably just the the stress of dialysis. And they say that it's got a 15 to 40% occurrence. And then, of course, dialysis causes dialytic trauma and the heart. They've found myocardial stunning, the transverse fibers, the longitudinal fibers, they all kind of get stunned as if a laser gun hit them on dialysis. And even this is in the absence of ultrafiltration. And so this myocardial stunning affects your contractile function. And so your patients will have more arrhythmias. And then in our dialysis patients, because of fluid overload, we have cardiac remodeling, we have left ventricular hypertrophy, and the statistics are that 75% of your patients on dialysis will have cardiac remodeling and left ventricular hypertrophy. And of course, when you have left ventricular hypertrophy, you also have reduced arterial compliance, and that interferes with the microcirculation. And the microcirculation is the tiny, tiny blood vessels in the brain and even all the way down to the bottom of your legs. And that would, if your patient's diabetic, then your microcirculation is impaired, and then you are at higher risk for infection. So it's really important that we pay attention to our patients' hearts, because two things: if we don't, then they can get hypotension, and then that hypotension also has bad results. And the lack of oxygen to the heart also contributes to cardiac mortality and morbidity. Next slide. So when we are talking about our hearts, and our hearts are pumping the blood all over the body, and remember we had that one slide where we showed that the heart and the brain are the biggest users of oxygen in the body. Well, when we look at cerebral blood flow in our dialysis patients, we all know that a natural consequence of aging, we get a little forgetful, we forget names, we forget faces. We know that cerebral blood flow decreases with age, and the jury is still out. Is it because of age, or is it because of bad diet, or is it because we're not exercising enough? But nonetheless, cerebral blood flow decreases. And it's important to have blood flow, because if you don't have blood flow, then you're not going to get oxygen to the tissues, right? So what they did is they took healthy, non-anemic dialysis patients, and they found when they looked at their cerebral blood flow, it was either normal or decreased, and then there was reduced blood supply to this regional cortical. And when there's reduced blood supply, there's reduced oxygen supply. And what they found was that during dialysis, the middle cerebral blood flow falls with increasing ultrafiltration. So once again, we have to be really careful about our UF rates. We have to take off enough fluid to decongest the heart and the lungs, but we still have to leave enough volume, obviously, to preserve the kidney if we have residual renal function or AKI, acute kidney injury. And then we also have to preserve blood flow to the brain. But most of all, I think we have to preserve oxygen supply to the brain, because we know that our dialysis patients have a lot of cognitive problems as a result of dialysis. And I wonder if those cognitive problems aren't magnified by the hypoxia of dialysis, because we know that 90% of our patients, at least once during their treatment, will have some kind of hypoxia. And just remember, the heart and the brain are high extract organs. They need oxygen to do their work. And if your patient's depressed, you can say, it's all in the head. Well, it is all in the head, meaning hypoxia and cerebral blood flow. Next slide.
Hey, Anne, would you like to take 5 minutes?
Sure.
Bathroom, drink, all that kind of stuff.
That would be great.
Let's take 7. We'll come back at 9:10. Is that okay with everybody? We'll
Perfect.
I'll leave the meeting open and the slide up. We'll just, we'll reconvene at that time.
Okay. Excellent.
All right, hopefully everybody had a chance to get a drink, stretch their legs a little bit, especially Anne, get a drink. That's a lot of information. Been chatting with some of the folks on the call, and they've conveyed that as well. A lot of information, but love the way that you're always able to break it down. So I'll turn it back over to you. Is the screen back up, everybody?
Yes.
Oh, I
Yes.
put you on mute, Anne, as well. You're gonna have to unmute Anne.
Okay, I'm unmuted. You can all hear me?
Got you now?
Yes.
Perfect. Okay. So as you can tell, my cerebral blood flow has decreased with age, right? So this is a really interesting study when we are talking about the brain. They did some neuroimaging studies, and they did adults and they did pediatrics. So with the adults on dialysis, they found white matter changes, they found cerebral atrophy and an osmotic demyelination syndrome, which is a really big word, but that has to do with the osmosis happening in the brain and little brain cells swelling during dialysis, which kind of is something they've found. Dialysis, and I'm going to pronounce it the Greek way, dialysis encephalopathy for those of you in Europe and England, but in America, dialysis encephalopathy. Hypertensive encephalopathy, so one of the causes of kidney disease and end-stage renal disease is hypertension, but then you also have hypertensive encephalopathy. This is really interesting. A lot of intracranial hemorrhage, microbleeds in 25 to 35% of our patients. So that begs the question about our anticoagulants. You know, we have to be really careful that we aren't giving our patients too many anticoagulants, right? We have to anticoagulate because we don't want to clot the dialyzer in the tubing, but we also have to wonder what's going on in the brain. They found cerebral ischemia and infarction. And remember when we were doing the definitions of hypoxia, one of the words was ischemia, and that was a lack of perfusion to that particular tissue. Well, here we have cerebral ischemia. We have lack of perfusion to the brain, and infarction, that's little clots. Infection even, sinus vein thrombosis, gadolinium accumulation. So that's if the patients have CT scans and all that stuff just stays in the brain. It's kind of like mercury is staying in the tissues of the fish. And so we have to be careful what fish we eat because the mercury is accumulating in their tissues. Well, the gadolinium is accumulating in our patient's brain if they have too many CT scans and other kinds of neuroimaging. And then dialysis disequilibrium. Now that was adults. And then when we go over to pediatrics, there was even cerebral atrophy in 23% of these kids. And this is kids, you know, the kids are high on the transplant list, and they found the cerebral atrophy even after transplant in 15% of the kids. Now you think of a 5-year-old that's about to start school and has to learn numbers and letters and reading and arithmetic, and they've already got cerebral atrophy. Well, that's going to impact a lifetime of learning, don't you think? And then the question is, are these changes due to osmotic changes in the brain during dialysis? We don't know. They found in kids, they had significantly enlarged ventricles in the brain. And fortunately, there was no sign of uremic encephalopathy. So what is causing these brain changes? Well, we can postulate that because the brain is a high user of oxygen, and then when you see what's happening in adults, it could just be a subclinical hypoxemia during dialysis, because we know that 90% of patients have some hypoxia during their dialysis treatment. And then if you take all of these frequencies and the time of hypoxia 3 times a week, 52 weeks a year, for as long as the patient lives, then those are just slow little hits to the brain. And many times disease is not so much an event as it is a process. So when we start the process of hypoxia, then I wonder what's happening over time. And these neuroimaging studies are giving us a clue. Okay, we got muted. That's good. So then there's also some more encephalopathy. And then there were ischemic lesions. Remember, ischemic is no blood supply. No blood supply is no oxygen. There were ischemic lesions in 54% of kids who got their transplant before the age of 5 years old. And then, of course, cortical infarcts. So it's really quite frightening when we actually dig deeper and look what's happening to the organs in the body in response to dialysis and hypoxia. Next slide. So we've done the transfer of oxygen across the alveolar capillary membrane. We've discussed the hemoglobin that carries the oxygen. We've discussed the heart, which is pumping the blood, which delivers the oxygen. Now we're going to talk about the hemoglobin, which actually has to release the oxygen. The hemoglobin picks up the oxygen in the lungs, and then it gets pumped to the tissues, and then the tissues take the oxygen out of the blood, and that's their fuel to do all of their cellular functions. And on dialysis, as you know, expenditure of energy is increased because dialysis is work. And if you think of each little cell in the body, it needs its oxygen. And what is the work that has to be done by each little cell in the body? 80% of urea is found in muscle, bone, and skin cells. So one of the things we do is we need to get rid of the urea. Well, the cell has to actually push the urea out of the cell so that it gets into the blood so that we can get it down and out through the dialyzer. So for each cell to do its work, it's needing the oxygen, and we have to have the hemoglobin release the oxygen. Otherwise, the cells don't get their oxygen. If the petrol pump is not working at Costco or wherever you're getting your petrol, then it doesn't matter how much petrol is in the tank or how much you need. If the pump's not working and the pump won't give you the petrol, you don't get petrol in your tank. Next slide. So we have something called the Burr effect, and our muscle cells are very dependent on oxygen, and also what affects the function of the cell is the pH. You know, we always check the pH on the machine, the PCO2, the temperature, and then there's DPG, diphosphoglycerate, and that's way too complicated for even me to wrap my head around. That's what the exercise physiologists talk about all day. But an exercising muscle, if you think of your dialysis patient, it's an exercising muscle, is acid, hypercarbic, and hot, and it benefits from increased uploading of oxygen from its capillaries. So the muscle needs that oxygen. It's got to have increased uploading of oxygen from the capillaries. And so this is where it's really important that the hemoglobin is able to give up the oxygen level. One of the things that potentially happens is because we're giving our patients a relative alkalosis. You know, our patients are chronically acidotic, but then because of the bicarb, we make them relatively alkalosis. And that alkalosis can actually interfere with the hemoglobin giving up the oxygen molecule so that the muscles and the cells can use it. Next slide. So at the end of the day, we've discussed the transfer of oxygen across the alveolar membrane. We've discussed the hemoglobin picking up the oxygen. We've discussed the heart pumping the oxygen. We've discussed the hemoglobin giving up the oxygen. Now the cells themselves need to be able to utilize the oxygen. Oxygen is necessary for every single chemical reaction in the cell. Every cell has a mitochondria. The mitochondria is the powerhouse of the cell, and the oxygen is the fuel for the powerhouse. Every single cell has cellular respiration. It's like every little cell is breathing, and it's doing that cellular respiration to make energy and to keep our bodies alive. Without oxygen to the cells, without the correct amount of oxygen to the cells, without enough hemoglobin, without the heart pumping properly, without the patient breathing properly, then without enough oxygen, energy production would cease and the vital activities needed for life would end and cells would die. And that's ultimately what happens with sepsis. With sepsis, the cells themselves are not able to utilize the oxygen that's delivered to them. It doesn't matter if the patient's on a ventilator. It doesn't matter if the patient has an LVAD. It doesn't matter if you gave the patient 2 units of packed cells. It doesn't matter if the patient's got oxygen supplementation. If the cells themselves cannot use the oxygen, then life ends, and that's death, and that's what multi-organ failure is. Next slide. So we're still talking about the cells and hypoxia. And one of the things that hypoxia does is it causes high reactive oxygen species levels. And that is just a mouthful. So what do these high levels of reactive oxygen species do? What they do is they promote inflammation and injury. So wherever you have inflammation, you're going to have problems. One of the lab results that we look at is C-reactive protein. And C-reactive protein is a marker of inflammation. If your patient has chronic high CRPs, then they're at higher risk for having a heart attack or other problems. So anything that promotes inflammation, we want to avoid. That's why diet is so important. That's why there's so much information about a plant-based whole food diet, because they're saying, you know, red meat promotes inflammation. And whenever you have anything that promotes inflammation and you have this chronic inflammation, then you're at risk for having heart attacks and strokes. And then this low oxygen also impairs the function of the red blood cells. Well, the red blood cells are what carries the hemoglobin, and the hemoglobin is what carries the oxygen. So it kind of becomes a vicious circle. If you're hypoxic, then you have all these other problems happening right at the physiological level. And then it basically promotes morbidity and mortality. So I think you're kind of starting to connect the dots is, wow, oxygen isn't everything, but it's right up there with money. It's affecting every single cell in the body. It's affecting my dialysis patient in ways that I didn't even realize. It's even affecting my dialysis treatment, my patient's ability to get through dialysis. It's affecting my patient's blood pressure. It's affecting my patient's cognitive ability. No wonder my patients aren't listening to me when I'm talking to them about their binders or their albumin because they've got cognitive dysfunction, and maybe the cognitive dysfunction is from hypoxia. Okay, next slide. So this is where we would have taken our break. But now we're going to talk. So now you know the physiology. You know the transport and utilization of oxygen. You know that circle of life about where oxygen can be interrupted at every single step, and how we need the lungs, the hemoglobin, the heart, the cells, how we need all of that to be working and what interferes with it working. So, okay, now we know oxygen is important. Well, how do we measure oxygen? And once we measure it, what do we do? How are we going to intervene? And what does it mean when my oxygen level is X, Y, or Z? So it doesn't matter if I go to the doctor and I say I have chest pain. If he doesn't do an EKG and he says, oh, go home and take Tums, if he doesn't get the information, he's not going to know how to respond, and he's not going to know how to make an assessment and make an intervention and give me a treatment. Okay, so next slide. So this section is actually pretty easy. The first section that we went through is when you really needed to be paying attention because there's just a lot of detail in physiology. But this one is kind of easy. This is just facts. It's not really critical thinking. So we have ways of measuring oxygen saturation, right? We can do arterial blood gases, and we just stick a needle into an artery, a radial artery, a brachial artery, a femoral artery, doesn't matter. We get an arterial blood specimen and we send it to the blood gas lab, and then they tell us what the O2 sat is. We can measure venous saturation, and that's usually a pulmonary artery. The patient's in the ICU and they've got a monitor that's giving us the information, and we can do pulse oximetry. We can put the oximeter on the patient's finger, and that's kind of cool because it's non-invasive. There are no needles, no catheters, and we just get a measurement. However, the pulse oximetry is actually calculated off of capillary blood. It's not measured. And then we can do blood volume monitoring. And that, to me, for the dialysis patient, is the best way because it's non-invasive. You're not taking any blood. You're not sticking any needles in to get your results. It's actually a measured number, and it's continuous, and it's real time, and it's a lab equivalent. So those are the 4 ways we can get oxygen saturation, and we can do arterial, we can do venous, we can do invasive, we can do non-invasive. So let's go to the next slide. And then what are the clinical practice guidelines? What is normal? And these actually came, I believe this comes from Britain. So thank you to the United Kingdom for giving me this information here to cite. So when do you give your patient oxygen? When is it appropriate or applicable or required that you give your patient oxygen? Well, whenever the patient has hypoxia. Well, what is hypoxia? It's defined, so whenever you see capital S, little a, O2, that stands for the saturation of arterial blood with oxygen, and we just call it the O2 sat, or we just call it the sat. So when do you give your patient oxygen? Whenever your sat is less than 90% in patients who are breathing room air, and or you think the number is too low for patients with a specific clinical situation. For example, if a patient's had a heart attack or if they have asthma, the doctor may say, write an order, give supplemental oxygen for SAT less than 94%. He wants his SAT in his heart attack patient or his asthma patient to be 94% or more. but it's defined as any saturation of less than 90% in patients who are breathing room air. Now, obviously, if there's an acute care situation in which you suspect hypoxia, your patient passed out, they're not talking to you, they're non-responsive, you don't have time to go measure what their SAT is, well, then you give them oxygen. That is an indication for oxygen. Your indications are when it's documented and when you have an acute care situation in which you suspect it. Then, of course, you're going to go get your measurements, you're going to get your pulse oximeter, or you're going to look at your numbers, you're going to send blood to the gas lab to get an actual SAT. And then, so, okay, well, wow, we can use oxygen in a lot of different places, right? Our dialysis patients, 90% of them have SATs of less than 90%. So we should be giving oxygen in all of our dialysis patients based on the indications in the clinical practice guidelines. The answer is most probably yes. What are the contraindications? When should you not give oxygen to a patient? The answer is there are no specific contraindications to oxygen therapy when indications are judged to be present. So if you have any of the indications, meaning a SAT of less than 90% or an acute care situation, then oxygen is always appropriate. Next slide. So now that we know that we pretty much can give supplemental oxygen to anybody pretty much anytime, obviously, we need an order. We don't just do it unless we have an order, because oxygen is a drug and drugs have to be prescribed by a physician. So you may know that your patient has indications for oxygen, but of course you don't just go give it because they've got indications. You still have to get an order. So what is your target saturation? A normal SAT, you should be targeting a SAT of 94 to 98%. So you always give oxygen until you can get a reliable measurement. And once you've got your measurement, you can adjust the flow. You know, the doctor will write an order 2 to 4 liters PRN, or 6 to 10 in an acute situation, or even I've had a patient who was on 8 liters of oxygen during dialysis. So depending on your order, you're targeting a SAT of 94 to 98%, and you're titrating your flow to get your SAT where you want the oxygen level to be. Now, if your patient has COPD, chronic obstructive pulmonary disease, they have emphysema, then your target saturation is 88 to 92%. And that is because too much oxygen can actually suppress the respiratory center in the patient with emphysema. So that's a pulmonary problem, but usually if you want to be safe, you really just want everybody's SAT to be above 90%, whether they have COPD or not. So your target 94 to 98, 88 to 92. But just to remember it easily, it's clinically significant if an oxygen saturation falls below 90%. Next slide. So when we have a patient who has a fistula or a graft, then we are getting arterial blood. And if we're doing continuous oxygen saturation with the blood volume monitor, we have the numbers in front of us. Or if you have a pulse oximeter, you can leave that on continually and you'll have an estimate of the O2 SAT. Your arterial SAT, the normal value is 97%. And like I said, it's clinically significant if it falls below 90%. So 90% is your safety net. Anything below that, you definitely want to be giving supplemental oxygen. Next slide. So we've spoken about the transport and utilization of oxygen. We've spoken about what's normal, what a normal SAT is. Now we're going to dig a little deeper because we've spoken a lot about hemoglobin. And now my question is, does this patient need supplemental oxygen? The patient's hemoglobin is 10 and their oxygen saturation is 94%. Remembering that I said it's clinically significant if it goes below 90%. So the next slide will give us some more information. We have to talk about the oxygen carrying capacity of blood. So hemoglobin, as you know, is what carries the oxygen. Normally, a female has a hemoglobin, normal hemoglobin 12 to 14, and a male has a normal hemoglobin of 14 to 16. 1 gram of hemoglobin can combine with 1.39 mils of oxygen. So that's kind of the most important piece that you have to remember on this slide, and you can actually just write it down. 1 gram of hemoglobin combines with 1.39 mils of oxygen. Just remember that 1.39 mil number, even though some of the literature says lower numbers, but we're going to use the top number to really make a point. So 1 gram of hemoglobin, hemoglobin is your oxygen carrying protein, can combine with 1.39 mils of oxygen. That's how much oxygen 1 gram of hemoglobin can carry. Okay, next slide. So the question was, does that patient need supplemental oxygen? And initially you're saying no, because the SAT is above 90%. However, your patient has a hemoglobin of 10. And so 10 grams, each carrying 1.39 mils of oxygen, you are delivering 13.9 mils of oxygen to the tissue bed. The tissues need 20 mils of oxygen in every 100 mils of blood. So even if your SAT is normal, that means that your hemoglobin is carrying all of the oxygen it can. It means that you're breathing okay. It means that your lungs are fine. It means that your hemoglobin's working. But if you don't have enough hemoglobin, you're not delivering enough oxygen to the tissue bed. And even if your SAT's normal, you still have hypoxia. You have anemic hypoxia. So it's also interesting when you're looking at your patient and you're looking at their hemoglobin and you go, oh, the SAT's fine, they're not short of breath. No, they're not short of breath. Their lungs are working fine, their blood pressure's fine, their pulse is fine, everything's looking good, but your hemoglobin is 10 or less. Well, if you do the math, you take the hemoglobin, you multiply by 1.39 mils, and you go, oh my gosh, this patient is not delivering 20 mils of oxygen in every 100 mils of blood to the tissue bed. This means my patient is hypoxic. And when your patient is hypoxic, they're not getting enough oxygen to the brain and the heart and the liver and the gut and the muscles. And you can predict that they will have either intradialytic morbidities like hypotension or cramping, or down the road, they're going to have all of those cardiac problems like the cardiac remodeling. They're going to have the little mini strokes. They're going to have the cognitive decline. They're going to have the decrease in white matter. And that's a process. And the process begins right here with anemia. So look at your patient's hemoglobin. And if your hemoglobin, I mean, I guess I'm just going to say it like it is. I was in this week actually, in a university hospital teaching some blood volume monitoring. And I'm not kidding, all those patients had hemoglobins of 7.8 to, I think 9.6 was the highest hemoglobin of all the acute patients who came into the dialysis unit. And none of them were on oxygen. And I was just I was just baffled. And I actually explained this slide to some of the doctors. And of course, they remember it from medical school, but we get so focused on the bicarb and the potassium and the dialysate flow and the blood flow. And are we using a Revaclear or a Nipro or a F250? What dialyzer are we using and how much time and how much mils? And we're not looking at the hemoglobin, and we're not going, oh my gosh, this patient doesn't have enough of the trucks that carry the goods to the facility. The patient does not have enough oxygen carrying capacity. Okay, next slide. So, and actually this happened to me on Friday. I explained the math and the doctor said, but if the SAT is 94%, then the hemoglobin is carrying all of the oxygen that it can. The hemoglobin can't carry any more oxygen. Yes, that is true. But remember that oxygen is water soluble. That's how the fish get oxygen in the ocean, because the oxygen dissolves in the water. So oxygen is water soluble, and a small amount of extra oxygen can be transported in the dissolved state in the blood when you increase the O2 to maximum by supplementing. Even though the amount carried by the hemoglobin is not changed, the small amount of oxygen that is carried in solution can actually be the difference between life and death. And the interesting thing is that this statement comes right out of the textbook of medical physiology. So next slide, we're going to talk about venous sats. Did we skip a couple slides or not? Did we do what normal venous sats are? Okay, here we go. Now we're back on track. So what are the factors that affect your arterial oxygenation? That could be your arterial sats. Arterial sats tell you how the lungs are doing. That's the most important thing that you need to know, is whenever your arterial sat is low, then it tells you about your patient's pulmonary function. So there are other factors that affect arterial sat, but in our world of dialysis, the most important thing affecting arterial sat is your patient's pulmonary status and your patient's anemic status, and of course, if they have low cardiac output. So arterial sats tell you how the lungs are doing. Next slide. Now we're going to talk about venous sats. But I'm missing what a normal venous sat is, so I'm just going to tell you what it is. Venous sats, when you have a catheter and you're measuring venous sats with a blood volume monitor, there we go. Here's our normal venous sats. Okay, normal venous sats. So when you have blood coming from a catheter, even though it's in the red tube going to the arterial end of the dialyzer, it's not arterial blood, it's venous blood. It comes from a vein, it comes from a central vein. A normal venous sat is 60 to 80. And if you have a blood volume monitor that's doing continuous measurement of saturation, you have to know what is the source of the blood. Is the blood an artery or is the blood a vein? If it's arterial, you want your sats to be above 90%. If it's venous, normal venous sat is 60 to 80%. Anything less than 60% is cardiac dysfunction. The heart's not working properly. Anything less than 35% is severe cardiac dysfunction. So everybody who's got a catheter is going to have a baseline venous sat based on how well their heart is functioning. Okay, next slide. So this just kind of explains why our venous sats are lower than our arterial sats. And we spoke about the carrying capacity of blood. So we'll just leave that yellow box out of our heads. But this is a good picture just to take a, if you want to take a photograph, because everything that I've just spoken about in the last 10 minutes is right on the slide. So you have your oxygen coming into your lungs, and then the lungs send the blood to the heart via the pulmonary veins, and then the heart pumps it in the arteries, the aorta and the arteries to the tissue bed. So that's why your arterial sats need to be above 90%, because that is freshly oxygenated blood. Then the exchange system at the bottom, that's the tissues, they take the oxygen out of the blood. So therefore the blood going back to the heart has a lower reading. And that's 60 to 80%, depending on how much the tissue is extracted. And then the heart says, thank you. And it sends the blood back to the lungs so that you can breathe out the carbon dioxide and then start everything again. And this is the figure of 8. It's, I want to say the circle of life, but it's the figure of 8 of life. Now, why does your venous sat tell you how your heart is doing? If your heart is not doing well, your heart is not pumping properly, your blood pressure is bad, your patient's going into cardiogenic shock, whatever, your heart's just not working like it's supposed to work, then these tissues at the bottom there where it says exchange system, those tissues go, oh my gosh, this heart is not delivering enough blood carrying oxygen. So everything in our body works by negative control feedback. So the tissues go, oh my gosh, this heart's not working properly. I need to take more oxygen out of the blood, because if I don't, I'm going to have cell death. So as a response to the heart not working correctly, the tissues extract more oxygen out of the blood. Therefore, the oxygen going back to the heart will have a lower sat. So if your arterial sat is 90% and the tissues are freaking out, they're going to take 40% of that oxygen out. So 90 minus 40 is 50. So your venous sat will be 50%, and that means that your patient has cardiac dysfunction. So if your patient ever has a sat of less than 60%, a venous sat that is, then you need to get a prescription for oxygen to support cardiac function. And you need to support cardiac function to prevent all of the problems associated with hypoxia, but you also need to support cardiac function so that you can have a better cardiac output, so that you can have a better blood pressure, so that you can continue to recruit the fluid so that you can get the patient to the ideal dry weight and decongest the lungs, decongest the heart, and get rid of that extracellular fluid. Okay, next slide. So this one is pretty complicated, but it's really not, because I kind of explained it in the previous slide where the tissues are going, oh my gosh, I'm not getting enough oxygen because this heart isn't working. So this is just the math of why the venous sat goes down when the heart's not working. We want cardiac output because blood pressure is cardiac output times peripheral vascular resistance. Blood pressure is the pump and it's the pipes. So if you want good blood pressure, you got to feed the pump and you got to feed the pipes, and they both have to be doing their work. So that's how come a venous saturation will tell you your patient's cardiac status. And then when you see that capital SCVO2, you go, oh my gosh, what are all these letters? It's the saturation of the central vein with oxygen. That's just a venous sat. So when your venous sat goes down in bold, it means your cardiac output has gone down. And when your cardiac output goes down, your blood pressure will go down. So if you have a monitor and you're getting continuous venous sats, you can actually be proactive. If you see that venous sat going down, you can be proactive and you can either decrease your patient's UF rate, or you can decrease the machine temperature, or you can give them oxygen, or you can give them pain medicine. You know, you can be proactive and prevent that blood pressure from going down if you see that venous sat going down. And there is literature for those of you that are working in acute units and you have a lot of catheters and you're using continuous blood volume monitoring with the continuous sat. There is literature that says if your baseline venous sat decreases by 7 percentage points, then that's predictive of hypotension. So if my baseline venous sat is 60 and I go down to 53%, you can predict I'm going to get low blood pressure. But if my baseline venous sat is 77%, which is still normal, and I go down to 70%, then that can also predict hypotension for me. So 70% is bad for me, but 53% is bad for somebody else. So with venous sats, it's all about your cardiac function. And I hope this is clear. Just take photographs of the slides and kind of process the information and dream about it. But the summary is arterial sats tell you how your lungs are doing. Venous sats tell you how your heart is doing. When your venous sat goes down, your blood pressure will go down. That's kind of the summary in a nutshell. Next slide. So we know that we have a lot of stress on dialysis. Myocardial stunning is what they've called it, and they actually discovered this myocardial stunning in pediatric patients in the United Kingdom. So when you have intradialytic events with any symptoms like cramps, headache, low blood pressure, fatigue, you also have intradialytic events with no symptoms, and the patient with no symptoms, without you knowing about it, if they do echoes or PET scans or CT scans, there's myocardial stunning, there's chronic ischemic brain injury, and there's organ damage. And those are very subtle, and we don't see them. But I believe that they are most likely due to hypoxia. I think hypoxia is a huge contributor to all of our dialysis comorbidities, the depression, the heart disease, the brain disease. And the literature, the researchers say that all of these problems, the myocardial stunning and the brain injury and the organ damage, they say it's due to a mismatch between oxygen delivery and oxygen consumption. Oxygen delivery is how much is getting delivered to the tissues, either because we're giving them oxygen in a nasal cannula or a mask and the heart's pumping it, that's oxygen delivery, and oxygen consumption is how much oxygen the tissues are using. So there's a mismatch between oxygen delivery. Are we not delivering enough oxygen, or are the tissues not using the oxygen that's delivered to them? We don't know the answer to that. But one of the hypotheses for this mismatch between delivery and consumption is a rapid blood volume reduction. And obviously you don't know if your blood volume reduction is rapid or not unless you're using blood volume monitoring and you can see the percent by which you change the blood volume. It's also caused potentially by biochemical changes. Remember, we're talking about acidosis and alkalosis, that's pH shifts. And complement activation, that's your pro-inflammatory. If you think about it, your blood is hitting this plastic tubing and the dialysis fibers, and all of that is foreign bodies, and that can also activate these inflammatory complements that happen during dialysis. So all of these things all contribute to dialysis stress. Next slide. So we have to talk about the oxygen extraction ratio. We really don't have to talk about it, but we're going to talk about it. So basically, that is the arterial blood goes to the tissues, and the tissues extract the oxygen. So really all it is the difference between the arterial sat and the venous sat. And normally, if your sat's 90%, the tissues will extract 20 to 30% of the oxygen, and then the blood going back to the heart will be a venous sat of 60 to 70. That's normal. That's what you and I are doing. That's what our tissues are doing. And this ratio, the difference between the patient's arterial sat and their venous sat, is actually a biomarker of hemodialysis-related hypoxic stress. And that's what we've been talking about for the last hour. We've been talking about hypoxia, and hypoxia causes stress. And this ratio actually increases significantly after 30 minutes, even though you may have no ultrafiltration. And when this happens, there's a reduction in those small blood vessels perfusing, and that's the micro blood vessels going to the brain, going to the liver, going to the gut, going to the muscles. And we don't see that on dialysis, but they see it on MRIs and PET scans. And you can't really tell what the microvascular perfusion is with your blood pressure and your pulse. And then the tissues increase their oxygen consumption prior to tissue ischemia. Remember, we work by negative control feedback mechanisms. So when the tissues go, oh, this heart's not working like it should, it's not delivering the goods that I'm expecting, and the tissues start extracting more oxygen, then the blood going back to the heart will have a lower sat, and this decrease in venous sat is an indication that you're going to have tissue ischemia. And tissue ischemia is really bad, particularly when it comes to the heart and when it comes to the brain, because the heart and the brain are your high extract organs. They need oxygen to do their work, and if they don't have oxygen, they're going to get damaged. Then this article tells us that the normal resting venous sat is 67%. I told you that normal was 60 to 80%. So that falls right into that range. And then when the tissues start taking more oxygen out that we can measure on dialysis, then that is associated with mortality. And it gives you the numbers if your pre-dialysis is less than 32 and your change is more than 40. So that's pretty technical stuff. You actually have to be measuring both your arterial sat and your venous sat to know what your oxygen extraction ratio is. But just know that if you have a catheter and you're using blood volume monitoring and you're measuring continuous venous sat, that when that venous sat goes down, it's bad. And so the only thing that we can do is to supplement the patient with oxygen. Why it's happening, we can't see because we're not doing MRIs and PETs. So we're going to do one more slide, and then we're going to have another 5-minute break because we're hitting the 10 o'clock hour. Okay, next slide. So at the end of the day, venous sat matters. And when we look, this is an amazing article by Dr. Chan. And if you can pull that article up on Google, it just basically explains in 6,000 dialysis sessions, when they looked at the venous sats, CVC is the central vein with the catheter. When they looked at those sats over 6 months and they followed them up for 3 years. They divided the venous sacs into two tertiles, and the lower venous sacs were associated with poor outcomes. Well, lower venous sac, we know venous sacs tell us how the heart is doing. So if the venous sacs are lower, then the heart's going to be worse. And of course, it's going to be associated with poor outcomes, right? And a 1% decrease in your average venous sat is associated with a 4% increase in mortality. So when you see a venous sat going down baseline by 1%, that means you're increasing your patient's mortality by 4%. So small changes make a big difference. That's like when the butterfly flaps its wings in Brazil, all these changes happen, and then you have a tornado in Texas. And it's the same in dialysis. Little changes make a big difference. And another thing, when we talk about little changes making a big difference, we're all talking about climate change, right? But do you know that the average temperature of the world has only gone up by 1 degree centigrade? It's only gone up by 2 degrees Fahrenheit. And yet that small increase in global temperature has made these massive changes in climate throughout the world. So basically, venous sat matters. Pay attention to your venous sat. And if it's less than 60%, you want to protect the heart, and you want to ask the doctor to write a prescription for supplemental oxygen. Okay, we are going to take a 5-minute break, or whatever Michael says. He's the boss.
Yeah, let's do
king,
for 5
so
minutes.
okay.
5 minutes, we'll come back 10:06. Just enough to stretch out and grab a drink, and we got about another 20 slides to go. So should be good timing. See y'all in a few.
Do we need to start again?
Are you not seeing the slides, Em?
I can see the slide. Can we start?
Yes, yes.
Oh,
sorry.
okay. Okay, cool. So we were talking about venous sats, and this is very specific for those of you that are doing access management and you're looking at your access maturation. So if you have continuous venous sat, there's actually research that lets you know that based on your venous sat, it's giving you information about the maturation of your AV fistula. That's complicated. That's a 1-hour presentation, but just so you know that, wow, venous sats really give us a lot of information. So we'll go to the next slide. And then this is just tracking the maturation of the access fistula or the AV fistula using your saturation. And it's pretty interesting how the venous sat changes, and you know, when the fistula matures and the heart is adapting to this new fistula. And remember, fistulas and grafts actually take 20% of cardiac output. So it sort of makes sense that, oh, wow, if venous sats tell me how cardiac output is doing, and fistulas and grafts demand 20% of cardiac output, and I have a new fistula, the heart's going to adapt. So that's pretty much what this is telling us. Next slide. So what are the factors that affect your venous sat? The higher your venous sat, the lower your demand for oxygen. And in our world, the most important reason for a sat that would be greater than 80% is the cells are just not using the oxygen. The oxygen is getting delivered to the cells, but the cells are not using the oxygen. And the number one reason for that in the dialysis patient is sepsis. So if your venous sat, and you know, you usually track your patients over time, you follow a trajectory. If your venous sat is normally hanging in the 60s and all of a sudden your patient has a sat 75, 82, you need to say what's wrong and you need to call the doctor, because it could be this patient is going into sepsis. So that's the most common reason for a sat being high, a venous sat being high, is the cells are not using the oxygen. All of the other things we're not going to get into. I mean, if they just came out of the recovery room and they're sedated or they've got too many pain medicines on board, it could be that the tissues just aren't using the oxygen delivered, but mostly it's sepsis. Now, I will tell you, anecdotally, I had one high venous sat that I could not understand. And the patient did not have any cardiac problems. The patient was fine. It was, we couldn't figure it out. Long story, there was a pinhole in the catheter, a tiny, minute little hole in the arterial end of the catheter, and hemoglobin has an affinity for oxygen. So even though it was a venous sat, just enough air was getting in through that pinhole in the where there was a little hole in the catheter, and that was increasing the venous sat. So the patient had to have their catheter exchanged. But that's obviously an extreme example. But what I'm saying, if your venous sat is too high, you need to really start paying attention and start digging to find out what's going on. A low venous sat means that the tissues are getting worried and the tissues are taking more oxygen, and what's going on? Your cardiac output is going down. If your patient is moving around and bouncing around in the bed or the chair or having an argument on the telephone, then also that'll lower the venous sat, but you know your patient's moving around. So when your patient is still, not eating, not moving, and the venous sat starts going down, then it tells you that cardiac output is going down. Next slide. So remember, we did all the causes of hypoxia, and this is just a different way of saying it. First, we spoke about the transport and utilization of oxygen, and we started at the lungs, where the oxygen has to cross the alveolar capillary membrane. If that's not happening like it should, we have hypoxia. That's a pulmonary problem. Then we spoke about the hemoglobin picking up the oxygen, and if the hemoglobin is not high enough, then we have anemic hypoxia. Then we spoke about the heart being able to pump the blood that's carrying the hemoglobin, that's carrying the oxygen to the tissue bed. And if the heart's not doing what it's supposed to do, then we have circulatory hypoxia. And then finally, at the cellular level, after the hemoglobin has given up the oxygen molecule and the cells use the oxygen, if the cells don't use the oxygen, then we have histotoxic hypoxia. So you can have any one of these wrong and you'll have hypoxia. Even though 3 of them are all working correctly, if one of them is wrong, you'll have hypoxia. For example, your lungs can be working fine, your SAT is great. Your heart can be working fine, your SAT is great. Your cells can be working fine, they're taking the oxygen. But if you're anemic, then you'll have anemic hypoxia. So if any one of these is not working like it should, you will have hypoxia, even though the other 3 are working perfectly. If one of them is not working, then we have a problem in paradise. Next slide. So, what can we do if our patients have hypoxia? It doesn't matter if it's pulmonary, it doesn't matter if it's circulatory, it doesn't matter if it's anemic, it doesn't matter if it's cellular. What do we do? And this is just an example of a patient who has a venous sat of less than 60. This patient has a problem. Even if the patient's blood pressure is fine, they're going down. We have to intervene. And on top of that, if you do the math, if you look at the hemoglobin and you do 9.2 times 1.39, your answer is going to be less than 20. So this patient has 2 reasons to need oxygen. Number 1, the venous sat is too low, and number 2, the hemoglobin is too low. Next slide. So, whenever we have hypotension, we have hypoperfusion. And whenever we have hypoperfusion, we don't have enough oxygen going to the tissue bed. That affects the brain, that affects the heart, that affects the gut, and it affects the kidney. And it's really important, particularly in your transplant patients. You've just given your patient a kidney transplant, they've got a sleepy kidney, and you are hoping for that kidney to start working so that you don't have to take it out. It's a brand new transplanted kidney. We have to be so careful to give that new transplanted kidney enough volume and enough oxygen so that it can start working. In AKI, acute kidney injury, we're always hoping for the outcome of renal recovery. So we have to protect that kidney any way we can. And once again, we have to be sure that the kidney is getting the flow that it needs and that it's getting the perfusion that it needs, because if it doesn't, then we can cause progressive renal damage. And we don't want to do that. We want to give our patients an improvement. We want to change their quality of life. So remember, hypotension is not good, which you know. There's hypoperfusion, but wherever you have hypotension, you most probably want to use oxygen supplementation to help the patient prevent all of these problems that we're looking at on the screen. We're looking at the brain, and we're looking at the heart, particularly in this picture. Next slide. So since we're talking about hypotension, and it's so cool because this comes right out of the literature. I didn't make this up and I just love it. What are our interventions to prevent hypotension? Well, there are a lot of things that we can do, but did you notice that oxygen therapy is one of the things that we can do to prevent hypotension and hypoxia avoidance? So with hypoxia, this is how hypoxia causes hypotension. Okay, your cell, let's just say it's a muscle cell or a heart cell. Your cell's not getting enough oxygen, and it says, oh my gosh, I'm not getting enough oxygen. So the cell releases adenosine, and adenosine blocks norepinephrine, all of these little physiological dominoes that are going on. And then the end result of that is vasodilation. So whenever the blood vessels are dilated, your blood pressure will go down. So that's how hypoxia causes hypotension. And if you want to prevent hypotension, then you need to avoid hypoxia. Next slide. So what causes hypotension? There are a lot of different causes of hypotension. And of course, we address each separate cause with medicines and treatments and therapeutic interventions and drugs and albumin and all of that. But if you look at the right, there's just one little word written in red, and that is hypoxia. So know that hypoxia causes hypotension. And if you have a patient with hypotension, I would say that the first thing you want to do for the hypotension is give the patient oxygen supplementation. Don't give saline if you can help it. And don't turn off the UF, because you want to decongest the heart and the lungs, and you want to decongest the lungs so that they can carry the oxygen to the heart. You want to decongest the heart so that it can pump and give you a good blood pressure. So I would say the first intervention for when your blood pressure starts trending down, definitely oxygen will help. And oxygen is necessary for cardiac function, because we learned that the heart is a high extract organ. So oxygen is necessary for cardiac function, and oxygen is also necessary for vascular tone. And you have to have vascular tone because blood pressure is cardiac output times peripheral vascular resistance. It's the pump and the pipes. So feed the pump and feed the pipes so that they can do their job and give you a good blood pressure, and you can get through your treatment without having to decrease the UF, without having to give saline, and you can get your patient to their dry weight easier, and you can also not leave them with extra sodium so that they go home and drink more. Next slide. So this is just a cool case study. Another good reason to use oxygen is that it helps recruit that extracellular fluid. So you know you've got water in the blood vessels. You can have too much, that's hypervolemia. You can have extracellular edema, that's where you can, have pitting edema, puffy eyes, facial puffiness, sacral puffiness, wet lungs, and then you can have intracellular edema, and intracellular is the water inside the cells. And normally we have 5 liters in the blood vessels, and we have 23 liters in the extracellular compartment, and we have, 11 liters in extracellular, 23 in intracellular. So we've got a lot of fluid in these different compartments in our body, and you can have intracellular edema or extracellular edema, but still we need to recruit that fluid. We need to get that fluid out of the tissues into the blood vessels so that we can get it down the dialyzer. So what does oxygen do? This slide shows you the patient's blood volume change, and you can see the patient starts at 0, and then the blood volume comes down to -5%, and at the arrow on the bottom is where we gave the patient oxygen, so the oxygen level went up. When we gave the patient oxygen, the blood volume also went up. So that is just an example of how oxygen helps recruit extracellular fluid. Albumin helps recruit extracellular fluid too. Not eating will help you, and also Trendelenburg, lying flat. So we have to do whatever we can to get that fluid to shift. And one of the things that we have, one of the tools we have is oxygen to help recruit that fluid so that we can have a great UF rate and try to get to the patient's ideal dry weight. Next slide. So this is one case study, and we're going to start, we're going to go back to our case study. Slides are advancing too quickly now. Okay, we're back to our case study, and we start at 0, and you can see the blood pressure is great. It's 112/63, and there's been no blood volume change. And oops, the oxygen saturation is 82% right off the bat. Anything less than 90 is clinically significant. So this is before we've even started dialysis. This patient has a low O2 sat. Then we wait 30 minutes, and we get our next set of vitals, and our blood pressure has gone down to 86/46. And our blood volume change is only -2%, and our O2 sat is 85%. It's still less than 90. So when you look at blood volume change and you say a 2% reduction in blood volume, what is that? Well, if you have 1 quart in a pitcher, or let's make it 1,000 mils in a jug of lemonade. We have some people from the Commonwealth and the British Empire here, right? So we'll do 1,000 mils in a jug, or we'll do a quart in a pitcher, and it can be lemonade, iced tea, just plain water. If you decrease the volume in that pitcher by 2%, what you've done is you've taken out 20 mils. You've taken 4 teaspoons. If you have a quart of lemonade and you take 4 teaspoons out of that, that's pretty insignificant. And that's what 2% is. When you reduce the patient's blood volume by 2%, you took out 4 teaspoons for every liter of volume. So that's an insignificant volume change. But the blood pressure has dumped down. And so normally we go, this patient doesn't tolerate fluid removal. No, they don't. But the question is why? Well, in this case, we have a monitor, and for the first time, we see that this patient starts with a low O2 sat. So we don't turn the UF off. We do not give the patient saline. We give the patient oxygen at 2 liters by nasal cannula. And then in 10 minutes, the blood pressure has crept up, and the blood volume has gone from -2 to -0.5. So the blood volume actually increased in response to the oxygen. And now the O2 sat is 94%, and we go, wow, blood pressure is getting better. The patient has a ton of fluid. Let's get this patient to his dry weight. So we increased the goal from 3 liters to 4.9 liters. And we just did it right off the bat because 4.9 was how much the patient needed to get to dry weight. And the common knowledge, this patient doesn't tolerate fluid removal, and we can only take off 3 liters at a time. And if that really was the case, then really that patient should have been dialyzing 5 times a week, but he wasn't. He was just getting more and more fluid overloaded, and he actually had pretty bad cellulitis. And I suspect that if we hadn't intervened and got him to his assumed dry weight, he might have ended up having an amputation. We don't know. Anyway, so moving right along, if we go to 1 hour, the blood pressure keeps going up and the oxygen saturation is normal, and an hour and 15, no, we're freaking out. So now we're doing vitals every 15 minutes because he went to 86/46, and I said, don't give him saline, don't turn off the UF. Well, then we better check the blood pressure every 15 minutes. But you can see from hour 1 hour and 15 minutes, it's the best blood pressure he's had, and his blood pressure just keeps being stable and keeps going up. And then after 4 hours, we got off our 4.9 liters. His ending blood volume was only minus 7.3%. This patient is still fluid overloaded. However, we did achieve his estimated dry weight, and the key word here is estimated. It obviously wasn't his correct dry weight because he didn't tolerate fluid. So you can just imagine every treatment just getting more and more fluid left behind. Of course he's going to have heart problems. Of course he's going to have an amputation. Of course he's going to have cellulitis. Of course he's going to have an interference in his microvascular. Of course he's going to have a problem with wound healing. And then he has to have an amputation. So this is just a perfect one treatment where oxygen made a difference because we looked at the numbers and we made the correct intervention. Next slide. So basically, is there a slide before this, or is it the slide after this? I think I'm missing a slide here. No. Let's go back to the, what is the slide before this one? Okay, so let's go to the, okay, there we go. Oxygen recruits extracellular fluid. Got it. We did that. We did that one. Next slide. Okay. So when we're looking at oxygen, if we have hypoxia, remember we said hypoxia causes vasodilation, and then vasodilation causes hypotension. And then when we have hypotension, we don't know what to do, so we lower the UF rate, and we give saline, and then we leave our patient volume overloaded, and then we have anemia and other cardiopulmonary complications. And then when we have anemia, we have hypoxia again. So we just keep going around and around in this vicious circle by treating the patient with decreased UF rate and giving them saline when they have hypoxia. If you have hypoxia, the treatment for hypoxia is oxygen. It's not saline. So let's start teasing apart the causes of hypotension. And right off the bat, I would say, start with oxygen and see if your blood pressure improves. You can check your blood pressure in 10 or 15 minutes, and I can guarantee you, you're going to have an improvement in blood pressure. Okay, next slide. Another thing that we can do to help our patients with hypoxia, there's literature research that says cold dialysate helps you prevent hypoxia. Now, in this study, they used a machine temperature of 34.5. Your patient will be shivering halfway to death. So, of course, that's not going to be tolerated unless you go to REI and get them a space blanket and you heat them from the outside in. But you don't want to heat them from the inside out. So cold dialysate works. Some of our doctors in the clinics where I've worked have the machine temp set to 36. Other patients or other facilities set the dialysate temperature between 36.4 and 35.8, and they adjust it using a blood temperature monitor. And when you decrease the dialysate temperature, when you have cool dialysate, then they found that the patients have less symptomatic hypotension, nausea, they need less saline, and they need less medication for morbid events. Now, if you think about it, if you just logically think about this, you know that our dialysis patients, I don't know when last one of my dialysis patients had a normal temperature unless they were getting sick and had an infection. But our dialysis patients come to dialysis and their temperatures are 96, 97 Fahrenheit or 36.5 centigrade. A normal Fahrenheit body temperature is 98.6. So I'm going to go Fahrenheit because I'm in the US and my metric brain is not working so well because of cognitive decline due to aging. So let's just stick to Fahrenheit. A normal Fahrenheit body temperature is 98.6. My dialysis patient has a body temperature of 97. But my dialysate, my machine temp, is set at 37, which is sort of normal body temperature. Normal body temperature in centigrade is 36.9. So we're taking our patients' temperatures in Fahrenheit, but we're setting our machine temperatures in centigrade. So no wonder we're all messed up and our brains are a bowl of spaghetti, right? But if my temperature is 36 and you've got my machine temp set at 37, what are you going to do? You're going to warm my blood. And when my blood is warm, I'm going to have vasodilation. And when I have vasodilation, my blood pressure is going to go down. So actually that cool dialysate does two things. It helps with vascular tone. And we also know from the research that it helps prevent hypoxia. So that's free. Cool dialysate is free. You don't have to spend any more money to help your patient prevent hypoxia. You just use your machine temp as an adjunct to your dialysis treatment. Next slide. So this is the little study where they individualized the dialysis temperature. And when the dialysis temperature was 36.1, they didn't notice any changes in cardiac output and total peripheral resistance, but the mean number of regional wall motion abnormalities, that's your cardiac stunning, was higher. So that was using your standard temperature default of 37, but when they individualized the dialysate temperature, the machine temperature, and they made the machine temperature lower than the patient's temperature, then the patients had better blood pressures and their peripheral vascular resistance increased. So actually a cool dialysate helps you with vascular tone. So dialyzing patients at their body temperature or lower is effective, simple, and cost-free. But if we just put everybody at 37, we're actually dialyzing the majority of our patients above their baseline body temperature. And that is not helpful if we want to prevent cardiac problems and vascular problems and blood pressure problems. So cool dialysate, free. Next slide. Okay, so dialysate cooling, basically this slide just tells you that hopefully it can prevent those acute ischemic brain insults, and reducing the dialysate temperature has a significant effect on hemodynamic stability, organ perfusion, and end organ damage. And what's not to like about that? Next slide. So if you have, remember we spoke about PIH, it stands for prolonged intradialytic hypoxia. What happens? Let's see the next slide. How does this hypoxia affect hospitalization and mortality? So this is 29,000 treatments. And the average saturation of these patients in almost 30,000 treatments was 92%. 10% of the time they were less than 90, and 3% of the time they were less than 87%. So all these patients spent some time with a SAT less than 90%. And 100 of those patients had prolonged intradialytic hypoxemia. They spent a lot of time with their SATs less than 90% and a slightly less amount of time with their SATs less than 87%. So the bottom line is, any time you spend with your oxygen saturation level less than 90% is not good. And the majority of patients spend at least some of their time with their oxygen saturation less than 90%. Now let's see what happened to these patients. Next slide. And then we should have their survival and their mortality. There we go. Okay. The blue line is when your SATs are above 60%, and then you can see in months when you die. The red line, you die a lot quicker when your venous SATs are less than 60%. So no matter what you do, whether you're measuring arterial SATs or venous SATs, if they're too low, it increases your patient's mortality. So any hypoxia in dialysis is bad, and prolonged intradialytic hypoxia is even worse. Next slide. And these slides, all they do is they just prove to you that oxygen affects mortality. If you don't have good SATs, you are going to die sooner. And this is just the evidence to prove that oxygen matters. It doesn't matter if you're measuring arterial SATs or venous SATs, it affects mortality. Never mind morbidity, never mind your brain function and how you feel and how your heart's beating up until the time that you do die. So definitely hypoxia is associated with higher mortality. Next slide. And then all-cause hospitalization. If you have prolonged intradialytic hypoxia, you have higher weight gains, you have more CHF, you have more COPD, you have higher ratio of neutrophils to lymphocytes, your albumin levels are lower, your hemoglobin's lower, your iron and your TSAT's lower. That all affects anemia. You use more EPO, you get more hospitalizations, and your mortality increases. So there's just nothing good about intradialytic hypoxemia. You can just see it's written down here. Take a photograph of that slide and just brand it into your brain. Next slide. So your higher ultrafiltration is also showing your venous SAT dropping. So cardiac function is definitely fluid dependent. If your venous SAT drops because you're removing too much fluid too quickly, then that's good. It affects your cardiac function. So this is all talking about cardiology, your preload. If your preload goes down, how much water's or how much blood's getting into your blood, into your heart, then obviously your cardiac output decreases. And we know your cardiac output decreases if we see your venous sat going down. Next slide. So this just shows you an example. This patient had a minimum venous sat of 39%. That's pretty bad cardiac function. And we were able to get it up to 45% by decongesting his heart and reducing his blood volume. Okay, next slide. Be bad when your hemoglobin is bad, because if your hemoglobin is bad, you're not getting enough oxygen to the heart. So in summary, I would say that oxygen supplementation is indicated, obviously, if your arterial sats are less than 90, if your venous sats are less than 60. If you have a low, you breathe fast, and if your hemoglobin is low. So those are just right off the bat when you can give your patient oxygen supplementation. And that is the end of this slideshow. And yes, some more reading if you would like to do some more reading and fill your brain with more information. Just remember, oxygen isn't everything, but it's right up there with money. And I do believe Michael is going to open it up to questions and comments.
And thank you so much. As always, I gotta just make note of this. I've seen you speak on this topic probably a half dozen times at least. And we're always in a show. I think Miss Clarica can probably testify to this, that we're always in a show where we've got an hour. And I think I've followed you and got my presentation cut short because you just have so much in there. So I really appreciate being able to go in depth into this topic and get the whole picture. There's a lot of things that stood out to me, and I'll kind of start it off with the questions. You mentioned the first intervention, or at least I'm kind of feeling a bit of an option here, but the first intervention as being oxygen for hypotension. And I'm just curious, you know, if we've got a patient that is trending down or a patient that is crashing, would that still apply that oxygen is first, or would Trendelenburg be a faster action while in tandem getting cannula and bringing over oxygen or whatever it might be? So what are your thoughts on that?
Yeah, so I would, if your patient is trending down and asymptomatic, then I would definitely give oxygen. But if your patient's crashing, then you need 3 people there, right? One to do the Trendelenburg and one to go get the O2 and one to turn off the UF rate.
Yeah.
So that's where we use our critical thinking. And I think that with oxygen, if we can be proactive, we're going to prevent the crash. And that's our goal, is to prevent the crashing.
Yeah.
So as soon as even when your patient starts, when they're feeling fine, if the hemoglobin's low, if the pulse is high, if the blood pressure is low, just give them oxygen right off the bat. Obviously, you need an order. You know, hopefully your doctor's given you orders O2, and you can document O2 given for hemoglobin 9.2, O2 given for blood pressure 96/84, O2 given for pulse 110. Just document why you're giving O2, because we're supposed to do critical thinking, right? And we don't just do stuff because, you know, it's got an order. If the state comes and reads your documentation, they want to see the narrative. So O2 given for history of intradialytic hypotension. There's actually an ICD-10 code for intradialytic hypotension. So definitely you can be proactive, but obviously if your patient's crashing, then you've got to do what you do just on reflex, which is Trendelenburg, turn off the UF, maybe even give saline, because obviously if your patient's crashing badly, I'm not going to say don't give saline, but I'm going to say try and avoid giving saline by being proactive. Does that make sense?
Yes, yes. And I have two more questions, and I'll let everybody else have a chance. Other question is your experience with dialysate temperature and the flexibility, or I guess the ability of the staff to do that. Doctor's order as needed, what standing order, what has your experience been? And maybe that's a question for the group as well.
Right. So pretty much we've had discussions about temperature and QAI. And you just present the evidence in the literature, and all of the slides have a citation. Mm-hmm. So my medical director in the clinic where I was a manager, we decreased our default temp from 37 to 36.5. And then we had a PRN 36. So we were actually allowed to, everybody was defaulted to 36.5 and then PRN 36. And we did the 36 for the patients that had the history of crashing or low blood pressure, or they had a cardiac history. I have only used 35.5 or 35.8 pretty much in an acute setting, but obviously the machine temperature is also a prescription. So you need to have a doctor's temperature. Now, I will be honest, and if I've had a patient that I think the machine temperature needs to be 36, I'll put the machine temperature to 36, and then I'll call the doctor and I'll say, hey, doctor, blah, 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 blah. Is it okay? I've put the machine temperature to 36, and the doctor will say yes. And obviously if he says no, then I run to that machine and I put it back to what it was.
Thank you. Yes. And then it looks like Ms. Clarica turned on her camera here. Would love if everybody could turn on their camera and we can get a group picture before we go. But I do have a question for the group. And, I am mainly in education, administration, operations side of things. I do consulting in clinics, and I can just tell you that I just came from a 3-day audit in a big clinic, and I didn't see one patient on oxygen, not one. I see in the chat that Gloria says that they're able to provide oxygen from the very start of the treatment in that clinic. Obviously, they have an understanding of the physiology, but from the group's perspective, for those of you that are out in the field, what are you seeing? Is oxygen being used as a proactive tool or a reactive tool in treating patients who are crashing?
Well, I found that it was I had to get more oxygen concentrators because I was always hospital based and we always had them on the wall. But then as I began to go to a clinic, a smaller clinic, it was not, you needed more patients. And I'm like, can you get more concentrators or something? So I found like I had to order more because I found like the oxygen was helpful. So thanks, good job, Miss Ann. That was a really great presentation. I appreciate it.
Thank you.
Thank you, Ms. Clarica. How about you, Jesus? Are you seeing oxygen utilized out in the facilities you're working as a proactive tool, or is it more reactive?
It's definitely a proactive. The nurse that I work with, she's very proactive when it comes to that. And if it's I notice that when we have a patient that has crashed more than 2 times or so, she orders oxygen right off the bat.
Yes, very good. Anybody else? Feedback on that? Okay, so I'll step off the question podium. Are there any questions that come up during this presentation, folks? All right, Anne, is there any last words? That doesn't sound good, does it?
Um, okay, let's see. If I was queen of the world, every single dialysis patient would have oxygen every single treatment. And I think I could find a clinical reason to give them oxygen.
Mhm.
And basically, we need to protect hearts and brains, right? I mean, who wants depression or who wants more white matter because they've been on dialysis for 3 years and we weren't giving the patient oxygen, we gave them cerebral ischemia instead? Or who wants to be admitted to the hospital with congestive heart failure? Or who needs to go to the hospital with anemia even, you know, because lack of oxygen shortens the lifespan of the red blood cell. I mean, lack of oxygen just does so many bad things that why would we not use it?
Right.
That's my question, is why would we not use it? And oxygen concentrators, all we need to do is plug them into the wall. Obviously, the tanks are really expensive. So the person that said, hey, I need more concentrators. Oh, I love it. I just love hearing that. That is so fantastic. And obviously you have experience and you've seen that it makes a difference. And for the doctor that prescribes oxygen, when your patient has had problems twice, that's amazing. You're actually responding and you're being proactive. I love it. So yeah, oxygen isn't everything, but it's right up there with money.
Thank you so much, everybody, for joining us. We will be sending out a follow-up email with instructions on how to avail the class for viewing, as well as to gain continuing education credit and our future events. Deneen, who is with our school, she handles a lot of our learning management systems, as well as most of the administrative stuff, has posted in the chat some of our social media tags. If you guys have taken any pictures or anything, or if we want to do that now, if everybody could turn on their camera, those of you who are willing to do that, we'll shoot a quick picture and then we can post it up on our social assets. You guys can chime in, follow us, engage with us, share this with others, because like I said, we'll be doing this every month, 3 hours with different topics. Richard just opened up his camera there. Some of you know Richard Cabrera with the hat and glasses there. He's one of the nation's experts and probably the world's experts in home dialysis, both hemodialysis and peritoneal dialysis. And he spoke at a lot of different conventions right alongside Anne, right along, I think me and Richard did a whole year tour together 1 year, like we were on every show together. So he'll be next month's speaker and it will be focused on home modality and the basics surrounding that. You know, he's got some surprises for us, I'm sure, with all the changes we've experienced since 2019 and the executive order surrounding the advancement of in kidney health, the push towards home modalities, and then now with COVID and what Anne spoke on is, you know, keep your patients from going to the hospital. Richard's words are going to be more relevant and more important than they ever have been, because we need to see a change in the setting of care for a good chunk of our patients. And I'll say that those that can should, and that's what Richard is doing. So again, thank you, everybody. If you're taking pictures, let's do our pictures now. Anybody else can open up their camera? No? All right, well, I'm gonna take a picture of you all. I can find my camera. I know Miss Clarica is like the queen of social media in nephrology, right? So she probably got a bunch of pictures already, but here we go.
I didn't, Mike, because I was in church.
Oh,
Oh my God.
I think we caught a few words, and they, you know, I know that it's not void, right, Clarica? Like we heard it. we cut in a couple of times.
Oh, that's right. Yeah.
Oh, you guys heard a little bit?
Yep, we caught it.
Oh my God, I'm so sorry. I stepped out.
Oh, you are too funny. May I say one more thing?
Yes, yes, please. Em.
I absolutely commend all of you for sacrificing 3
Yes.
hours of time. That just tells me your commitment to education and to knowledge. And honestly, I am just amazed at every single one of you that sat and listened to me blab on for 3 hours about oxygen. I mean, you are the stars of dialysis, and please just keep doing what you're doing and keep encouraging everybody. And you are just the bedrock of success in dialysis. So I really commend all of you for literally a 3 hour on a Sunday sacrifice. That is just awesome. That just makes my heart swell with joy.
Likewise, I'll just add to that, you know, holiday season, travel, all of that stuff, you know, church. You came, you showed, and I know you're walking away with something today. Share this with your teammates as far as the knowledge that you've gained. Share this with your patients as far as the practicality of this knowledge, and let's make people's lives better. Happy holidays to y'all. I'll see you next year, and I look forward to the emails that we'll be sending out.
Merry Christmas. Thank you.
Merry Christmas, everybody.
Merry Christmas, everybody.
Thank you for the instruction. Very valuable.
Thank you.
You're welcome.
Bye-bye.